things where it's marked impairment in functioning, but it also can be functioning in relationships as well. So remember, it doesn't have to be just marked impairment for that individual. It can be marked impairment relationships, social functioning, work, home care, you know, a number of different areas go into functioning as well. Yes? Yeah. Yeah, so the question was, can it go on for months and a long, long time? Yes, it certainly can. So it has to go for at least a week. Generally, if we don't have sleep for a long time, generally that's something that just biologically will call us to crash at some point. So generally there's that piece. Or maybe it borders on psychotic features and then we get hospitalised, and that's what kind of brings us down, because then you get medications to sort of tranquilise all of that. But no, it can certainly go on. That client that I described, it was quite a number of sessions, at least a month, that he was just like, yeah, way up there in terms of things. Yeah. Other questions? So the question was, some of these symptoms are reminiscent of ADHD in a way, and certainly that's something that you would have to rule out. But this is a little different from ADHD in terms of just the combinations of symptoms, you know, in terms of the grandiosity and self-esteem. That's not a typical piece of ADHD necessarily, but certainly the distractibility portion could be quite possible. You will know the difference between somebody that's in a manic episode versus ADHD. I can't actually emphasize this talkative piece. Like, that's just, I mean, I could attempt to reminisce and be like, and its volume increase. I mean, it's like so... It's just so marked in contrast to what you would expect that once you've actually seen somebody in a manic episode versus ADHD, it's quite different in presentation. But you certainly need to rule out those types of criteria as well. Yeah. Yes. Mm-hmm. So the question was about what triggers these manic episodes, and we are going to get to etiology in this lecture, so I'll shelve that because we are going to get to the different hypotheses around what might actually underlie the onset of this episode. But thank you, good question. You're just leading me into my next piece of today. Okay, so contrasted to a hypomanic episode, this meets most of the criteria for a manic episode that we just went over, except it's not as severe. So whereas if we go back, a manic episode had to be at least 1 week of these symptoms, here with a hypomanic episode, it's only 4 consecutive days. It does have to represent a change in functioning, so this is not just a highly energised, distractible person. This is a change in functioning, whereas, you know, ADHD is sort of pretty consistent on medications. This is a change in functioning in terms of pre-hypomanic episode to hypomanic episode, and that change has to be observable to others. The other piece here, though, is that with a hypomanic episode, it's not at the level of severity that causes marked impairment in social or occupational functioning. Doesn't get that sort of almost psychotic level, so it doesn't necessitate hospitalisation, and there's certainly no psychotic features with a hypomanic episode. So it meets some of those criteria of a manic episode, but it's not quite as severe. So this is bipolar 2 disorder, remember. So if somebody meets criteria for a manic episode, that puts them into bipolar 1. So then we have a number of specifiers that go along with this, and I won't go over all of these. You do spend some time in your tutorials differentiating which specifiers go along with things. And again, this provides further information that informs your case formulation and also your treatment approach. So in terms of likely differentials, so there's medical disorders that you would want to rule out because some of these conditions are associated with similar symptoms. And then we also need to rule out whether the manic episode was triggered by use of drugs, for example, or whether that manic episode occurred and then the person was taking drugs as a function of that manic episode. So that temporal sequence again, can sometimes get a little difficult to differentiate, particularly when somebody's memory of that time is impaired by the substances as well as the symptoms. And so the psychiatric disorders, in terms of special consideration for differentials and ruling out disorders, so schizophrenia, like we talked about last week, and personality disorders as well, which we will talk about later in this course. So looking at the course of bipolar disorder, what I might actually do before we touch on that, let's take a 5-minute break. I was thinking I was going to try to get through the bipolar and then take a break, but it has been an hour and you're probably uncomfortable. So let's come back in 5 minutes' time, so about 1:07. Okay, so let's get started back up. So in terms of the course of bipolar disorder, so bipolar disorder often starts with depression, a major depressive episode, and that's the case within 75% of females and 67% of males, that it generally starts with a depressive episode prior to the manic episode. And again, generally the age of onset is around 18 to 22 years for both males and females, because if you recall, this is one of those disorders that's relatively equally distributed between males and females. This also is a recurring illness in terms of the cycles of depressive episodes, manic episodes as well. So generally it's not like you just have one episode and then it's gone. If that were the case, that they had one episode and then they never have it again, likely it was a misdiagnosis to begin with, because probably it was substance-induced manic episode if they've only ever had one and no recurring symptoms at all after that. So you'd have to question the accuracy of that diagnosis if it did not recur to a certain extent, at least some symptoms, unless it's appropriately medically managed, for example. Most experience a combination of depression and manic episodes, and 10 to 20% will experience only manic episodes with bipolar 1, but most experience sort of a combination of depression, hypomanic and manic episodes. And as these episodes increase, as the chronicity of the disorder continues, so as the duration of symptoms continues, the amount of time between episodes of depressive episodes or manic episodes, generally that time decreases between episodes. So it really is an emotional roller coaster for the person, as well as the person in that, in their life, if this is not appropriately managed. So the prognosis for bipolar disorders 1 and 2 is generally worse than depressive disorders, and those with pure manic episodes do better than those with depressed or mixed symptoms. This is a lot to do with medications. If there's only one symptom, it's much easier to target that than it is to target a host of varying symptoms. And so in terms of prognosis, if we've got shorter duration of manic episodes, that generally leads to better outcomes. older age of onset generally also leads to better outcomes. Few suicidal thoughts, that leads to better outcomes because actually suicidality is very high in bipolar. So if you don't have the thoughts to begin with, then you're less likely to actually complete suicide. So certainly if you don't have the thoughts, that's a good prognostic indicator. And also if you've got a quote-unquote simplified version of the disorder. So as soon as you start getting on mixed symptoms, adding on depression, adding on coexisting psychiatric or medical problems, all of that builds complexity and contributes to a worse prognosis over time in terms of disability, functional impairment, etc. And so, as you can see with the levels of impairment of bipolar, occupational impairment is high, affects 20 to 50%. Social and interpersonal impairment is also very high in bipolar. So certainly the rates of divorce are higher among people that have a bipolar disorder diagnosis versus just a major depressive disorder diagnosis. Also with bipolar, alcohol abuse, that also increases the morbidity associated with this condition as well. And really the more severe the diagnosis of bipolar, the more frequent engagement in risky behaviours as well. So that's why you have the more frequent alcoholism going along with severity, because it kind of ramps up the engagement in risky behaviours like taking drugs, promiscuity, those types of symptoms. And suicidal behaviour, as I just mentioned, is higher, but really the prognosis is it improves when the bipolar symptoms are under control. Sounds quite obvious, but really this is one of those conditions where you really need medications as well as psychological treatments, but it's definitely one of those things that needs medication, and you'll see that in your book they state that as well.